What is myasthenia? Myasthenia is an autoimmune disease characterized by the blocking of the motor endplate receptors through autoimmune antibodies produced by our body and targeting postsynaptic acetylcholine receptors. This condition predominantly affects young women aged 20 to 40. The thymus plays a significant role in this condition by stimulating the production of antibodies against neuromuscular junction receptors, responsible for the postsynaptic blockade. The thymus is the organ primarily responsible for the production and maturation of immune cells. Keep in mind that the thymus becomes functionally less active over time. The clinical presentation of myasthenia includes several distinct features. Patients may present with unilateral or asymmetric bilateral ptosis. Ptosis is when the upper eyelid drops over the eye. Transient diplopia. Diplopia is the simultaneous perception of two images of a single object that may be displaced horizontally or vertically in relation to each other. An occasional strabismus or misaligned eyes is a condition in which one eye is turned in a direction that is different from the other one and preserved intrinsic muscle function. These muscles are responsible for controlling the movement of the eye, allowing us to focus on an object, track movement, and perceive our surroundings accurately. Facial involvement is evident in the patient's face, with symptoms such as drooping jaw and open mouth, reduced wrinkles, and anemic faces, or a lack of facial expressions. The patient may also present other signs involving dysphonia, which refers to having an abnormal voice, chewing and swallowing difficulties. The forward head posture and respiratory distress caused by a respiratory muscle failure contribute to the severity of the condition. Additionally, a waddling gait and difficulty rising from a squatting position, also known as Gower's signs, may be observed during a clinical examination. In the workup of diagnosis, the goal is to elicit the myasthenic phenomenon by conducting repeated and sustained movements, such as eyelid closure, which reveal the signs we talked about before, which is ptosis. Symptoms tend to worsen with fatigue, typically at the end of the day, but they improve with rest. There is something that makes this condition different from other neurological pathologies, which is the presence of negative signs, include the absence of sensory symptoms. Sensory pertains to the mechanism through which our body detects and receives information from the environment. It involves various sensory organs like the eye, ears, nose, tongue, and skin. Some other negative symptoms include normal reflex and sensations. Sensation refers to the actual conscious experience or perception that arises in our mind as a result of the sensory input received by our body. For example, seeing a beautiful sunset, hearing the music, etc. The third negative symptom is the absence of any vegetative disturbance, such as sphincter dysfunction. To aid in the diagnosis, various tests are conducted, starting with an electroneurommyography to assess for a decremented response in repetitive stimulations. The decrement pattern at low rates of repetitive nerve stimulation is characterized by a decreased in compound muscle action potential size within the first 4 to 5 responses. Pharmacological tests involve intravenous administration of anticholinesterase agents, resulting in the regression or disappearance of objective neurological signs, particularly the obvious ones like ptosis. Testing for anti-acetylcholine receptor antibodies can be positive in approximately 80% of cases, while testing for anti-MuSK antibodies is positive in 40% of patients who are negative for anti-acetylcholine receptor antibodies. MuSK is a tyrosine kinase receptor predominantly located on the postsynaptic membrane of the neuromuscular junction. Chest CT or MRI scans are used to look for potential residual thymic tissue or thymoma. Thymoma is a type of tumor that occurs in the thymus gland. Immunological assessment aims to identify associated autoimmune disease, including anti-thyroid antibodies, T3, T4, rheumatoid factor, and anti-DNA antibodies. The disease course of myasthenia is irregular and somewhat unpredictable. Possible exacerbation factors can worsen the condition include medication, muscle overuse, or high physical activity, as well as some surgical procedures and more. This exacerbation can manifest as either myasthenic crisis or cholinergic crisis secondary to anticholinesterase overdose. Such crises are marked by muscle weakness, excessive salivation, bronchuria, autonomic symptoms, miosis, bradycardia, and respiratory distress, with a potentially life-threatening prognosis. So, how myasthenia is being treated? Anticholinesterase agents are the mainstay of treatment, working to extend the action of acetylcholine through reversible blockade of acetylcholinesterase. In cases of generalized myasthenia, treatment options include thymectomy, prednisolone in combination with immunosuppressants if persistent bothersome symptoms persist, and utilization of plasma exchange during acute exacerbation. For ocular myasthenia, corticosteroid or immunosuppressant are rarely used.
Thanks for watching.